So the objectives today are just to help to, we hope that you'll be able to better evaluate children with chronic irritability and mood dysregulation with consideration of the social environmental factors and using a person-centered collaborative approach. Be able to discuss some of the differential diagnosis of children and adolescents with disruptive mood dysregulation disorder. And I'm going to just refer to that as DMDD for the rest of the didactic to save time. And to identify and discuss treatment options for DMDD, including appropriate referral sources. So bipolar disorder versus severe mood dysregulation. I know back working in Mahoning County, we had something that we kind of playfully referred to as Belmont Pines bipolar, because for a very long time, any child who was admitted to Belmont Pines, one of the two, at the time, local children's mental health hospitals, pretty much everybody came out with a bipolar diagnosis. So that's really the kind of thing that led to this shift, because we had seen a rise in the number of pediatric visits with with a bipolar diagnosis going from 25 per 100,000 jumping to 1,003 per 100,000. Definitely not that many kids have bipolar disorder, but we were seeing a lot of things with chronically irritable moods and behavior issues that no other diagnosis exactly fit right. So in contrast to bipolar disorder or hypomania, severe mood dysregulation is defined by the chronic non-episodic irritability. So this is an all of the time irritable kind of mood, an exaggerated emotional reactivity and hyperarousal. And what they have seen is that there's a relationship between chronic early irritability and later depressive disorders. So not so much the mania and things that you would see with bipolar, but a longer-term depressive issue. So DMDD was added to the DSM-5 in 2013, and it was identified as having, so the criteria are severe temper outbursts at least 3 times a week. So these are things that are happening very frequently, and they can be verbal or physical, but they're grossly out of proportion in intensity and duration to whatever the situation was that provoked it, and inconsistent with developmental levels. So if somebody is developmentally delayed, you're not going to look at these outbursts in the same way. In between all of those outbursts is a sad, irritable, and persistently angry mood most of the day, pretty much every day. And these symptoms go on for at least a year without a 3-month window without symptoms. So this is really a persistent, very problematic type of mood disorder. Symptoms had to have been present before age 10, but it's diagnosable between ages 6 and 18. So it can be comorbid with some things and it can't with others, and that's where we're going to get into some of the differential diagnosis. And I think it's fair to say that a lot of this is a work in progress, given that it's a newer diagnosis, but the way that it's being conceptualized is that DMDD can co-occur with a major depressive disorder, and it sounds like in more cases than not will eventually transition into a major depressive disorder diagnosis. It can co-occur with anxiety, ADHD, conduct disorder, and substance use disorders. What they do not want to see it ever being diagnosed with, because it should not, it's kind of one or the other, is bipolar disorder, ODD, or oppositional defiant disorder, and intermittent explosive disorder. So the differences. When you're looking at DMDD versus bipolar, DMDD has that chronic irritability, and the typical mood within DMDD is consistently irritable and angry. These are just unhappy kiddos, constantly unhappy. Versus bipolar disorder, you get that variable mood, and things go in episodes, and they tend to kind of fluctuate up and down. So you've got a normal mood to depressed to manic. But DMDD kids are like that all of the time, almost every day, most of the entire day, in between these massive outbursts. DMDD versus intermittent explosive disorder, and this is where it's a little bit trickier, but in DMDD, you actually have more outbursts more often. So it's at least 3 times a week versus intermittent explosive, you only would need 2 times a week, and you only need that criteria to be met for 3 months, where DMDD is an entire year. So when it's being looked at like this, it's more of early on, you can diagnose it as intermittent explosive disorder, but if it's persisted to be a year long or more, you should be really looking at the consideration for DMDD rather than intermittent explosive. I'm going to tangentially pause very quickly just to let you know that we do have an issue with fruit flies in the room today. So if you see us waving our hands rapidly and oddly, that's why.
I'm hallucinating, but
The rest are okay.
Well, other than Dave, we're all okay, just fruit flies.
I'll just mention, since you paused, one other thing. Intermittent explosive disorder, usually what happens is people can't figure out the trigger. Whereas in DMDD, the theory is that there is a trigger, but the usually child is reacting overly strongly to that, whatever that trigger is. So IED, usually you can't even figure out what it was. They just have this explosion. So it's another.
Yeah, that's a very good point. DMDD versus oppositional defiant disorder. Again, how frequent and pervasive the outbursts are going to be a major issue. DMDD, you also have that persistently irritable angry, where you don't necessarily have that. In ODD, you might have irritable and angry. You also might have argumentative and defiant, and often you can have vindictive. So you're not necessarily going to see vindictive behavior with DMDD. It's more of that just generally angry. And while I think you'd see some argumentative and defiance, it's a bit different. And with the outbursts, I think this is similar to what you said with intermittent explosive disorder. With oppositional defiant, you're going to see outbursts as a reaction to being told to do something or not getting their way. DMDD, it could be almost anything. And it's going to be completely bizarre, but it might not have been about being defiant. It's just a huge overreaction. So prevalence, and this was something a little bit hard to nail down because it's not been a diagnosis for very long. So even the couple studies that I was able to pull were looking retrospectively and trying to piece out which kiddos met the criteria based on the way that we currently understand it. But I pulled from two major studies. One looked at a 3-month prevalence rate, and it was a huge number of kids. And they did diagnostic interviews with each of them. And they were able to find a range anywhere between 0.8% up to 3.33% with that highest rate of diagnosis criteria within the preschool age. Except then when they went to a strict application of the exclusion criteria, then those numbers were not exactly the same. So anywhere from 0.8 up to 3.3, but that's still not entirely sure. The highest co-occurrence was with depressive disorders and with oppositional defiant disorders. And again, that's one of those places that you would need to do a differential diagnosis. It's either ODD or DMDD. But 62 to 92% of the time that they were looking at this group of kids, the DMDD co-occurred with some other disorder. And 32 to 68% of the time it was with both an emotional disorder and a behavioral disorder. They also saw a lot of elevated rates of social impairments, school suspension, service use, and poverty, which I think is to be expected, particularly with the social impairment, school suspension, given that you have to display severe impairment in at least one of the 2 locations that you're having impairment in. A more recent study looked retrospectively at a community mental health center's population and looked at all of the children that had been serviced between the years 2003 and 2008 and looked to see which of them would meet criteria for DMDD. And out of all of the kids in that treatment setting, 31% of them actually met that criteria. And 40% of the kids in that population met criteria for a diagnosis of oppositional defiant disorder. The ones who met the criteria for DMDD almost always had the diagnosis of ODD, because at the time, that's the diagnosis that would have existed. That or bipolar, you would have seen a lot. And they had higher rates of comorbidity with ADHD and conduct disorder than the kids who did not have the criteria for DMDD. So treatment options. So I looked a little bit into the medications, and we'll lean on my, my physician and pharmacist collaborators here to kind of fill in the dots with this. But when they looked at stimulants, the thought was, well, there's some efficacy of using stimulants in kids with ADHD in response to, any type of the aggression or more overt angry types of behaviors. You see some of that reduced. So methylphenidate was one of the ones that they looked at in a larger study with behavioral management. And the two groups within that had response to ADHD symptoms also saw a reduction in the severe mood dysregulation symptoms, or what looked like manic symptoms. Their takeaway from that was that because it was a combined approach, there might be evidence for being able to get rid of some of the mood dysregulation and address that without medications. Atomoxetine?
Strattera.
I got to get better at that, though. Sarah's keeping me on my toes with all of the generic names. Atomoxetine was not shown to show reductions in any of the aggressive symptoms, so that's worth looking at. So we've got stimulants that might be helpful, but the non-stimulants, because Strattera is not a stimulant, is it?
No, it's more SSRI-like, I think. But in theory, it's first line for ADHD, but nobody seems to use it. Everybody jumps to stimulants.
Well, it apparently doesn't show reductions in aggressive symptoms for this. There was a little bit of research on antipsychotic medications, and they had a meta-analysis that looked at risperidone compared to placebo, and it did have a strong effect on aggression and has been shown to shorten the duration of rages in children who've been in the hospital. However, according to the authors, as much as there is evidence for the efficacy of using these with irritability and aggression, the side effects, long-term, short-term, really do limit how much we should be using antipsychotic medications with kids when we don't have to. Another one that they looked at was divalproic acid, and for mood dysregulation, they actually had 2 double-blind placebo-controlled studies, and in a study of 20 kids with oppositional defiant disorder or conduct disorder, mostly adolescents, but when you looked at the symptoms, they were similar to what would have been DMDD criteria. 8 out of 10 of those kids responded and were able to show better mood regulation, where 0 out of 10 responded to placebo. So there's maybe something there. Cognitive behavioral therapy was the one that I found probably the most literature around in terms of psychosocial types of therapies. CBT, and we know, can be used for a lot of different things. One of the cases that I found, though, talked about, yes, it's completely feasible to use CBT, is probably better for younger kids, or better for adolescents than it is younger kids, but there was some adaptations that an author of one of the studies was recommending if you're going to make it work best for kids with DMDD. So they talked about extending the psychoeducation piece of CBT to include things around dealing with prolonged irritable episodes, identifying triggers, giving some meaning and words to that common feeling of being stuck in a particular mood, maybe even helping kids create a creative metaphor or some way of externalizing and talking about that. Another thing that they focused on adapting was emphasizing the behavioral activation that would be needed to reduce prolonged periods of a negative mood. Building more emotional regulation for reducing the duration of irritable mood periods, and actually extending, if a typical set of CBT sessions was 8 to 10 sessions, they were saying you really needed to give them extra sessions and a longer transition out of counseling so that you can focus on decreasing the non-episodic irritability and allow for a more gradual transition. There was another study that looked at dialectical behavior therapy with some modifications for children and its ability to be used with kids with DMDD. And the study showed that you can use it with kids as young as 7 through 12 to get to severe emotional and behavioral dysregulation, including the suicidality that you might see and non-suicidal self-injurious behavior. And this makes sense to me because a lot of the things that we see behaviorally and emotionally with borderline personality disorder or kind of in a smaller, kind of really intense version when you think about DMDD. I mean, so these are kids that are not responding well or identifying their emotions. They're reacting in ways that seem very similar to borderline personality on the surface. So teaching them how to identify, talk about, and regulate their emotions makes perfect sense to me. Yeah.
What is dialectical behavior therapy?
Dialectical behavior therapy has been developed and has been shown to be one of the few treatment options that work really well for people with borderline personality because it teaches them to identify and regulate their emotions. It's very similar to CBT in that way, but it gets into a lot more of the actually being able to pull yourself up and then back down.
It's a lot of training to do it, to become a DBT certified person. It was created by Dr. Linehan, who later, a psychologist who later admitted as she got older that she created it for herself. She had a serious problem with borderline personality disorder, and she actually, psychologist healed myself. And then it's worked for lots of people. But so you really need a trained person to sit. It's not something that even most psychiatrists do, maybe not. I mean, it's very specialized.
And not even most therapists. I mean, I've read books on it and I've definitely employed techniques from it in working with people, but to truly practice dialectical behavior therapy, it's, I think, like a week-long training, and you should have supervision and ongoing, contact with other people who are practicing in order to practice it to fidelity.
Okay.
But it can be used in a group setting or individual.
I was just going to say it tends to be a pretty intensive treatment. So they're engaged with the person who's doing DBT for a period of time, and they do like to use the groups because then it's the interpersonal communication piece where they can practice some of those techniques in a supervised setting.
So it kind of gets into a little bit of social skills training in that way too. So DBT for kids with disruptive mood dysregulation disorder, when the study looked at it, not only was it able to be used, but the kids and the parents tended to find it acceptable, understandable, kid-friendly, and helpful to them. They noted that parents being active participants was huge and could be even more important than the child being super engaged, and that some symptom relief could be achieved without any kind of pharmacological interventions by using this technique. They did specify, and with the parent aspect though, that you needed to teach parents more than just parenting techniques. So yes, we want to teach parents about reinforcement, extinction, punishment, shaping, modeling, but that wasn't really enough for these kids. You also needed to teach them how to validate. So really being able to be the foundation of change for their kids, how to create a change-ready environment, so improving that parent-child relationship, practicing skills on a daily basis with kids, being able to model the skills that they were trying to teach their children and help their children to adapt to, and to teach the parents how to achieve their own emotional regulation needed to successfully implement behavior modification. So a big piece of being able to do this as a parent and create the right environment at home is also being able to modulate your own behavior and your own reaction to these kids. They're not an easy group. And that's a couple of the things that I found were actually case studies. And I pulled just a little bit about this kiddo out. And I've definitely worked with these children, and I think that it's a nice point about why we need to teach the parents how to even adapt to their own living environment. Because when you look at this very quick case study, so 8-year-old boy, parents at their wits' end due to his emotional outbursts, parents will say things like, "It's gotten to the point where I dislike my child." Temper outbursts can occur several times a day that will last approximately 10 minutes, and sometimes more intense could be 30-minute outbursts, again, several times a week. During outbursts, this young man might become physically aggressive, kick, punches holes in the doors, walls. Mom says bruises are on her body pretty regularly from her attempts to block his strikes at her. Parents will describe him as irritable, cranky for the better part of the day on most days. And when he's irritable, he appears agitated and restless. When trying to talk with their child, he often expresses that he wants to be left alone. Attempts to cheer him up are unsuccessful and sometimes even make it worse. So at 8 years old, he'd be in the 2nd grade, but put into a restrictive classroom setting, classified under special education as emotionally disturbed. Probably a smaller classroom setting, less kids. Might have been suspended, up to 3 times for physical aggression towards school personnel, throwing chairs, knocking over a bookcase. These are kids that will hit their teachers, punch, kick, throw, spit. Cognitive abilities are typically ranging from average to superior. So it's not like this is a developmental or intellectual disability. The kids will still struggle academically, and largely due to the large amount of time that they have to be out of the classroom because of their disruptive behavior. Teachers will note them to be irritable, agitated, and that they're pleasantly surprised when these kids smile or appear happy. Teachers will feel like they're walking on eggshells. Parents will feel like they're walking on eggshells. So a lot of the work in helping the support systems around these kids is helping those support systems not to be completely burnt out and actually still have the energy to engage them. So questions, discussion. Have you seen these kinds of kiddos?